with first, just to show everybody the implant that we were talking about. So this is an SLA model. This is not the true allograft model, but it looks exactly like this. And you see it's got 2 holes drilled in there for the screws, for the 5 cortical screws. And then it also has, I've already put the sutures in it, so this does not come loaded like this. So all I do is make a little loop of a suture, like that, put the Ethibond or fiber wire through it, and then what I do is I just pull that so that now that creates a sliding suture so that you can then pass this through the capsule, and then you have a sliding knot that you can actually just slide down into the joint for them. So that, and then I pass 3 of those sutures. So that's usually the construct I have. As you can see, the holes, because they're drilled, you can, if you don't like the sutures and the capsule being repaired out here, you can just turn this around and put the sutures in the other way so that they come out this side, okay? So the suture holes are pre-drilled in the graft, all right? Now you don't have to use them. There's only 1 for each of them, so that you either have to put a knot or something to prevent the suture from pulling out from the other side. I wouldn't recommend drilling into this because, you know, it already has holes in it, so if you happen to cross one of the holes, you don't want to fracture your allograft and then lose the allograft for it. But you can drill holes into the adjacent glenoid if you want to put an anchor inside that and don't want to put it in here. So these are just an option for you to use these sutures. I put the sutures in, but some people don't like to sew anything to it, they just put the screws in. The kits come with a guide. So here's the guide here. Now this black line on it is where your cut plane is going to be. So usually what I do is I take that black line right down to the glenoid bone loss area and just a little bit further. This usually aligns with the back part of the glenoid. So once that pin line is in, you'll see that pin is just past the back edge of that circle. So that you know if you have this sitting in the face of the glenoid, that your screw length is going to be right at that interface there, so that it's long enough. So that's the depth that you're going to measure for your screw length, okay? Usually I can tell you that they're about 28, 30, 32 maximum. You never really need much more than that. For checking's sake, even though I know the length, I always put a depth gauge in just to make sure that that's the right length that I want to use. So let me just move on to the exposure. This is a little bit bigger incision than I usually use, but anterior deltopectoral. And then, so pec, medial, deltoid lateral. This is the conjoint tendon here, all right? This is the pec minor here. So if you were doing a Glenojet, you're going to release this pec minor here like this, okay? And take that off. And I just want to show you, here's the neurovascular bundle. The plexus is right here, okay? So obviously you're cutting with your saw there, there's the plexus there, so it's a little bit close. That's why sometimes. Now, if you're really interested in leaving the anatomy but taking the sling effect, this is what I do. I just take this, usually with a cautery, and I just take this off subperiosteally. So there you see, there's the edge of the conjoint tendon right there, and you just dissect down this interval here. All right, and here, down in this area right here is the musculocutaneous nerve, right in there. All right, so you just have to be careful of some of these nervous branches that are coming off to that. But you can take that, then I put some stay sutures in there, and then I can sew that to the front of the glenoid, to the bone graft, and you can utilize some of those sutures that I put in there, okay? So I'm not going to do that today, but I just wanted to make sure that you understood that you can actually use that. So now that I've cut that, it's there, but normally I would retract that out of the way, all right? And so I'm just going to put it down there. And just to show you now, this is the subscapularis muscle here, okay? So if you're just doing the glenoid, you don't have to take the subscap off so that you don't have to worry about it healing. So what I do is a split, and you can see this tendinous portion here. So it's usually about not quite half and half. I'd say it's a 1/3, 2/3 split, all right? So 1/3, 2/3. And then it's easier to find here over where the muscle is, and you just split the muscle, and then you can find the capsule and then follow it out. And then you just dissect, and I just subperiosteally dissect this usually. And I've already done it so that you can see it, but there's the interval between the capsule and the subscap, and I've taken it all the way off medially. Now just to show you, here's the glenohumeral joint right here. So you see I have great exposure of the glenoid, and I've got this all the way out to here. Now, so if you're doing a subscap split approach, you can then cut your capsule like this. So this is the capsule off the glenoid. Now a lot of times this is already torn because it's a bankart, obviously. there's your glenoid. You see we have a great exposure. I put a retractor here on the neck of the glenoid to keep the subscap out of the way. I put a Gelpi retractor in here to keep this wide open for me. So you put the Fukuda in, so you can split the muscle over, and then with the Gelpi in here, you can see most of the glenoid there. I don't know if everybody can see that. So the other way of doing this is a tenotomy. So the tenotomy, you have to be careful you don't cut the biceps. So usually I go about 1.5 centimeters off of this. I've already exposed, there's the interval, there's the supraspinatus there. Okay, here's the interval, there's the top of the subscap. And then I usually leave a little soft tissue stump and I just do a tenotomy off of the tuberosity, about 1.5 centimeters or so, and I angle this downwards. And what I do is I take it to the bottom. Here's the vessels here. You can see normally you have to cauterize those. And then just extend that out. And so once you've taken this off, then I just take this off completely off the neck of the humerus. So you see you expose that, and there's your capsule there. Here's our glenohumeral ligaments there. You can just release this up to, and then there's your humeral head there, and you can externally rotate this now. And then you have, so normally I put a DARA, I don't put anything sharp back there, but I put it intra-articular, and I put it like that. You can take that one out, or yeah. So now this is exposed. Your Hill-Sachs defect is going to be right here. All right, so if you're doing a hemicap like I showed you in those pictures, what I would do now is expose my defect, put my pin in, ream this out, and put in my metal implant to cover the defect, which is back here, okay? I do that first, and then what I do is I let this fall back into the joint, and then I move back to do my glenoid, okay? So what we do is we put that onto the glenoid. So you just drill this down until the line meets. Another one? Yes, there's two sizes. There's a regular and a large. Okay. Let's do it. All right, so now what we do now is then take the reamer over top of the pins, down onto the glenoid, and like I said, it has a positive stop. And you can see in the window here, the pin coming up. You just got to pay attention to the stop. So it's right at the bottom. It's bottomed out. You can hear it. You take that, and then you move it to the other one. Okay. So you can see now that we've reamed now down to a nice bleeding bed here. See the bleeding bed of bone on the glenoid there? I don't know if you can see that or not. Just have a look there, guys, if you want. And then at this point, it's a matter of taking your graft, sliding it down over top of the pins. So that I leave the other pin in so that it at least keeps me centered and I see where I want to go. And then this just goes straight down the tube. All right, so as I put this in, I just put my finger here, and I always feel that go down. I don't over tighten this yet because I haven't got my second screw in yet, but you can feel it just grabbing now. So I don't over tighten that just yet. All right, you can see that I'm down and I feel pretty good in terms of the front. And then I take my second pin out. Good. All right, you can see, and now you see the compression happening. And then I just tighten my screws up. All right, there you go. My capsule is here. Remember we detached it? And so what I would do is I just take that capsule, back up like that, and sew it right there. And then this is the conjoint tendon. You can just sew that to that too, so that you have it, and then just put it in. You just put. Okay. Awesome. Perfect. Thanks, guys.